So what I'd like to do today is to cover it as quickly as possible, give a definition of OCD so we have a sense of what we're talking about, talk about the prevalence both in the normative sample and in children with autism spectrum disorders, look at the issues of differential diagnosis with OCD and autism spectrum disorders, the overlap and comorbidity of the two. We need to look at the empirically supported treatments available for children on the spectrum, talk about what modifications might be necessary to apply those treatments, and then if I have time to look at the resources available. I will try to gloss over as much material as possible. We have left some references for you, both some academic references and some books for your own pleasure in reading for later on. So, let's talk a bit about OCD and the definitions thereof. Obsessions are unwanted, uninvited thoughts, images, or urges that do not remit. They will not go away. They are, by definition, significantly anxiety-producing and distressing. And that has to be a key feature. We need to separate out these obsessive and anxiety-provoking thoughts from what we would consider to be sort of typical worries. Am I going to pay my taxes? Separate from things that get into our mind like silly memes about cats on the internet or something like that that just won't leave. That's not an obsession. It needs to be anxiety-provoking, significantly so. The individual who has the obsessive thinking will work excessively hard to get rid of the thought, to either suppress it, to neutralize it, or to avoid it altogether. And there's a huge amount of cognitive effort involved in that. I don't know if you can read that. This is the chicken on the planet saying, did I turn the oven off? When we look at obsessions, we'll give you some examples. Contamination. So this is sort of the classic one that most people will think of when they think of OCD, the classic hand washer. Someone who showers for long periods of time. Obsessions can take the form of symmetry, so they need to have perfect balance. So for example, someone scratching their left ear, feeling they need to just scratch that right to get it perfectly balanced. Some aggressive themes. I've worked with some individuals who have suffered significantly, worried that they're going to push someone into the street or push a small person in front of the SkyTrain. Some religious concerns about going against moral conduct or code. Sexual obsessions. Pathological doubt is something I'm sure we've all been accused of at times, but this is different. Pathological doubt in this case would be more than just did I turn the stove off, but things like when I was driving to work today, I remember hitting a bump. Did I maybe hit somebody? Is someone hurt? Is someone in my family hurt? It's really quite significant and very distressing. Unacceptable urges, again, we all think we have those, and we do, generally speaking. But these would be things like aggression, so concern I'm going to reach out and punch someone, concern I'm going to swear at Tony suddenly in this talk. That would be an example of an urge that I just can't get out of my mind, and it's quite distressing. Compulsions, then, by definition, are actions or thoughts that we engage in to specifically get rid of the obsessive thought and the anxiety associated with it. It may or may not be visible. In fact, generally speaking, most compulsions you see are just the tip of the iceberg. There are a lot more cognitive things going on that you may be aware of. They need to be repetitive in nature, often done in patterns. If you meet someone with OCD, they will either be in even or odd camp. So they will do their activities twice or 3 times, 5, 7, 4, or 8. Often includes both a physical and a thought pattern. So when you are measuring and watching for, you can't just go by observation alone. You need to ask some of the cognitive questions to find out what they may be. And they need to be separate from what we would consider to be typical habits or rituals. So if you brush your teeth exactly the same every day, that's not a compulsion. If you follow a certain route on your way to work, that's not a compulsion. They need to be separate from what we consider to be also superstitions. If you watch a batter going up to bat or a sports player, a hockey player circling around the ice, they will do it exactly the same every time. They may not shave. Those are superstitions, but not necessarily compulsions. Some examples of compulsions might include, again, the classic hand washing, cleaning, making sure that whatever I touched did not contaminate me. I might get sick. Or worse, I might go home and make my mom sick by what I've brought with me. The need to check. So did I close the door when I left the house? Is the stove off? Is my locker locked? Have I done something wrong? Did I leave something outside so my little sister's going to trip on it? Counting compulsions. So these are kids that, for example, have the need to count the stairs as they go up to school. If they get bumped and lose track, they have to go back and start again. It has to be done. Again, that need for symmetry or just right. I recall working with a poor colleague of mine in grad school, and whenever he would leave the room to go to the bathroom, someone would rearrange his papers, he'd come back, and he'd spend some time getting them just right. And that's often the phrase you'll hear when you do a clinical intervention, is people will talk about the need to have things just so or just right. The need to confess. That may sound like a good thing if you're a parent and your child has this, but this can take an inordinate amount of time, so the need to confess what's happened in the course of your entire day. I've had students that have been really upset going up to a teacher saying, you know, when I was doing my math test, I might have looked over at Tony's paper. I don't know if I did or not. I think my whole exam's not worth it. Can I please throw it out? Compulsions may take the form of repeating rituals, ordering, and or hoarding. The OCD pattern, as we can imagine it, is quite reinforcing and quite rewarding. So we can imagine if my fear, obsessive thought, is that in touching this piece of wood here, I may have just touched something that someone else did and now they're sick and I'm afraid I'm going to get that. My anxiety starts to rise significantly to the point where I'm now very, very anxious and distressed and I can't get that thought out. So I go wash my hands, and as soon as I do, my anxiety drops. I feel much more relaxed. So the next time I go near something dirty, I'm just going to avoid it and go wash my hands and get rid of that thought. I don't want to experience that level of anxiety again. If there was such thing as a compulsive list of things to do, it might look something like this. So when we talk about the prevalence of OCD, in the normative sample, it's generally considered to be between 1% and 2% of the population. It's still a significant number. In the literature, if you're looking at autism spectrum and then apply the OCD features over top of that, generally speaking, 17 to 30%, very comparable to what Dr. McConnell was talking about roughly 25% of individuals on the autism spectrum will have enough features, clinical features of OCD to warrant a diagnosis. If we talk about the symptom overlap, there are a number. One just needs to go to the DSM-5, look at the series of restricted and repetitive patterns of behavior, things like stereotype, repetitive motor movements, use of objects or speech, pacing back and forth, insistence on sameness, inflexibility, ritualized patterns or behaviors, restricted or fixated interests, the need to watch the same movie repeatedly, the need to go through the same pattern to say the same thing repeatedly, all have a very obsessive-like quality to them. So if we take the two diagnoses separately and look at them, we clearly have some overlap. So to begin with, ritualized patterns of behavior, either verbal or nonverbal, those are clearly in both conditions. As is the resistance to change. An individual who has OCD does not really, particularly in kids, has a hard time starting to work on that because it's quite anxiety-provoking to imagine stopping doing what you're doing, which also leads to an insistence on sameness. There are some significant differences, however, when you're looking at ASD and OCD. An individual who has just OCD, those compulsions are designed specifically to reduce stress. And most importantly, they do not bring pleasure. They're not fun. Individuals who have to do compulsions aren't enjoying washing their hands. They don't like going back and forth through the doorway 20, 50 times. The individual on the autism spectrum, we know, those compulsions can be experienced as, well, kind of pleasurable, right? If I get to go and do the thing that I really like to do, not only do I feel relaxed doing it, does it not calm me, but I kind of enjoy doing it. Huge distinction. Likewise, the content of the obsessions for most children with OCD tend to hover around those contamination, pathological doubt, superstitions. Whereas individuals on the spectrum, those tend to be more around the restricted interests. So strong interest in Minecraft, the need to continually talk about certain things, the Titanic, perseverative interests, some behavioral things like rubbing or rocking, pacing back and forth. Again, very different. Likewise, the obsessions are experienced as intrusive in someone who has OCD alone and uncontrollable. An individual on the spectrum, generally those experienced as important, somewhat controllable, although that's arguable, and don't create a great deal of resistance. So when we look at the two disorders then, we need to look at three specific factors when we're making a differential diagnosis. One, we need to think about the emotional content or valence or the strength of the emotion associated with the obsessions and compulsions. If the individual is really experience a huge amount of distress and anxiety overdoing these compulsions and anxiety, then automatically we want to consider OCD in addition to autism spectrum disorder. If they're enjoying it, if it seems to be pleasurable and reducing stress, we don't want to target that. We want to look at the content of those obsessions and compulsions. So if they are more stereotypically related to things like cleaning, organizing, pathological doubt, again, we want to think of OCD. And finally, we want to look at the functional aspect of these. Is the individual engaging in their compulsions to just be calm? Is it self-stimming, or is it in reaction to an anxious thought being provoked by an obsession? The empirically supported treatments out there, we would look at applied behavior analysis. So this is the big B that was talked about earlier, looking at, and for sort of what people would say would be more behavioral kinds of aspects, so things like ritualistic behaviors, ordering, arranging. Applied behavior analysis is quite useful, and the literature is quite replete with lots of good examples of that. Cognitive behavioral therapy, which was covered for me, thank you, is singularly the best researched and clearly the most specific in terms of working with children and adults with OCD. There is a slow and growing literature, again, as Dr. McConnell talked about, saying that OCD and children in autism spectrum disorders is amenable to a CBT or a modified CBT protocol. Again, exposure is key. For most individual protocols, specifically CBT protocols for autism spectrum disorder and OCD specifically, you need an exposure response prevention. So essentially, if my concern is that I've touched this wood and I now have a contaminated hand, I immediately want to go wash it. If I'm being worked with a clinician, that clinician may then work with me to build up some time between when I touch this and how soon I wash my hands, so that I build up some habituation and eventually it will become extinct. Medication, as was talked on already, so I'll just go over it. SSRIs in the literature, there's strong literature to support that children and adults can benefit. The general understanding is if the individual has a significant severe OCD, sometimes the combination of the two is the most effective. If they're in a more mild symptom presentation, then CBT would be your first line. Any modifications you want to look for, number one, as we're talked about, is now we know we need to look for OCD and autism spectrum. If you are currently doing CBT in your practice, you are already trained and know how to do CBT with individuals with autism. There really is no difference. The modifications are quite minor. So I'll just add to some of the ones that Dr. McConnell talked about. So clearly we only want to target those obsessions that are ego dystonic or stress-inducing. So if they're anxious, and these individuals are upset by doing them, that's the one you target. Modify the protocol according to cognitive ability, obviously. Need to incorporate a social skills element, even in CBT. Anyone I've ever worked with who has OCD works exceedingly hard to hide their symptoms. It's embarrassing. It's a little crazy sounding for most people, so they work hard at hiding them. Individuals on the spectrum may not have the same social scrutiny, so they may be engaged in their compulsions in a way that would be quite obvious and only add to the unfortunate social challenges they might have. And then also need to be mindful of the strong emotional reactivity and sensory input. The modification, I'm going to back up. So for example, if I was going to work an exposure response with someone to be able to work with germs, for example, I may want to work them eventually to get to the public bathroom where they could actually turn the taps on without it being upset. An individual with autism, I have to be aware, what does the bathroom smell like? How loud is that toilet when it flushes? So there's a strong sensory reaction piece that you have to include if you're going to be looking at a CBT protocol. And the last one was visual age, which we covered before. And finally, there are some resources out there. This is not new. CBT for OCD has been around for a long time. It's well researched and it's quite well organized. As I said, if you are currently doing it now for individuals that don't have autism, you're in a great position to be able to provide to these individuals because the modifications are minor. There's some good resources we've included in there, some books, literature, some great websites that will cover some of the more specifics that I've glossed over. And I think at that point, my timing is finished. Thank you.